Good afternoon, everybody. Thank you so much for being at this session today at CUGH2025. Honestly, the positivity that we have heard here has been really inspirational for us and for all of us at CUGH. As I said before this morning, your presence gives us all hope and enables us to be able to move forward in these challenging times. And I hope that each of you are meeting new people, reinvigorating old friendships, and above all else, that the fact that we're here together, know that we're not alone, and each of us are here to support each other. So as you can imagine, on this particular plenary on impacting global health challenges, when it was constructed, the world was a different place. So what we're doing today is, with our incredible panel that we have today, we decided to create this panel to be able to give you different perspectives, very different perspectives, but important perspectives on how to get things done in this environment. And we're very honored to be able to have 5 different individuals here who will provide us with that. So what we're going to do is I'll introduce everybody very briefly. You can see everybody's bios in the vFairs app. And then each of our guest speakers today will be able to speak to us for about 3 to 5 minutes each. We'll go into some questions and answers, and then it's your turn to ask our speakers here the questions that you want. And the purpose of this is to really get into the guts of how you get things done on the ground. As I mentioned, each individual here comes to that question from a different perspective and a very important one. So I'll go in the order in which they're speaking. First up is a very good friend of CUGH and a great guide and a mentor for our organization. For me personally, it's a real honor to have Ambassador Jimmy Coker here. Ambassador Coker has had a 30-year career with the U.S. State Department. He's been an ambassador in a number of places. And in fact, at 9/11, we were actually in Ouagadougou at the same time, which I obviously didn't know until very recently. He was the Assistant Secretary for Global Affairs at the Health and Human Services. Next up is Dr. Jimena Villalba-Garçon. Dr. Jimena Villalba-Garçon was Ecuador's Minister of Public Health, and she had that position during COVID. So she was the lead person saving lives in her country in that vitally important position. Currently, she is the Dean of Public Health at the University of San Francisco in Quito, Ecuador, and is a member of our board, so we're very lucky to have Jimena there. Next is Dr. Sumash Kumar. Dr. Kumar is a Senior Director, Technical Leadership and Program Development at JPIGO, a major implementer of global health programs around the world. And Sumesh will give us that perspective from an implementer's perspective. Next is Dr. Catherine Machabala, who has been an incredible leader in One Health in the environmental space for quite a few years. She is the first an inaugural planetary health scientist at the Nature Conservancy. But Catherine's experiences runs far afield from the World Bank to the WHO and internationally, and right down to vital community work that she does in West Africa, and will bring in the environmental, human development space in these questions. Next is another board member and a wonderful friend of CUGH, Dr. Elsie Kujuli-Malawadi. Dr. Kujuli-Malawadi is the first female radiologist in Uganda. Yes. She was also the president of the African Forum for Research in Education and Health, a great friend and collaborator of CUGH. Again, currently a CUGH board member, and she's a director at HEST in Uganda. So you can see we have an incredible array of leaders with vast experience who will bring different perspectives to this fundamental question. So first up, I'll turn it over to Ambassador Coker. Ambassador Coker, thank you for being here.
Well, thank you, Keith, and thanks to the audience. And we've got a packed house for what is a topical question, but I first have to issue the disclaimer, even though I'm still part-time associated with the U.S. government and the State Department. I'm not here representing the U.S. government and have no particular insights into what's going on or what could happen. But I can give you the perspective I have from having been in the U.S. government for a long time and being as in as uncharted waters as the rest of us are. I think it's important to realize that global health funding globally reached its peak during COVID and has actually been declining for 2023 and 2024. But the threats to global health funding pre-existed certainly the US election or changes in other donor attitudes, the requirements of climate, of migration, of emergencies, of conflicts, and also the inability of partners like yourselves and even within governments to move money from, for instance, emergency response to services or to research. So we have the color of the money has been more and more restricted, which has meant that more and more things have been earmarked and the flexibility of both the donors and the partner governments, partner organizations have been restricted. 2025, almost surely the total amount available for global health from donors and maybe even from national contributions will decline. The U.S. represents in global health uniquely, not in all development assistance, but in global health, about 40% of public sector funding, international development assistance. And I think our challenge here is to be sure that we're identifying the baby in the bathwater, which is surely being thrown away. And we do need to refocus on what has direct benefits to the American population, the populations we're serving, and what's life-saving. What does that mean? And it certainly doesn't mean just at the verge of death to intervene, but what are the implications of the various services that the U.S. government is funding and that many of you are involved in researching or in implementing, and how do we relate those to the sense of prosperity and security and safety of the American people? I've heard even at this conference several references to the global health architecture, as though this were designed by a blueprint and we were building it in careful order. We know that's not true, and so we say, well, there's a global health landscape. Maybe we didn't design it, but we can describe it. But I think even that isn't fair because it's moving all the time, and the metaphor I like to use is that there's a global health traffic jam. And we are each in a vehicle, we're each trying to get someplace, we each have a good destination and a way to get there. And if there's not a storm, if there's not a crash, most of us on most days can get to where we're going and fulfill the purposes for which we've undertaken the project or the organization we have. But as soon as there is a storm or there is a crash, there's gridlock. And we don't have an express lane, we don't have a bicycle lane. There's no one in charge of this traffic. And so if something happens, there's no one to say, clear this lane and let's move ahead in that direction or redirect your vehicle to where the need is. And there's also no one who can kind of go on the side and get to the last mile and say, there are people who aren't being reached by this superhighway. We need to get the services to them. And I think this has been a challenge for a long time, but it will be increased if many of the global level donors aren't talking to each other, for instance, the US government and the World Health Organization. So in thinking of how we as a group can work on that, we certainly need to pay attention to the details. What are the details of the programs that need to be saved and reinforced? But also to the big picture. I think it would be a shame to compete against each other to say, well, I'm going to save my program, but at the cost of yours. And we simply don't know where this is going to end up. And I think that it's important that we not lose hope and that we not lose the motivation that brought us to this in the first place. So be aware of the ecosystem in which global health is taking place and in which donor-implementer relations are taking place. Look for strategic partnerships. Let's huddle together for warmth when it is cold outside. And that solidarity is the reason we are in this profession to begin with, in these activities, and that trust is in short supply. And so let's try to create safe spaces and to find areas of increased collaboration, even when times are tough, or I would say especially when times are tough. Thanks.
Thank you very much, Jimmy. Please. Thank you, Amena.
Thank you, Keith, and thank you for the invitation. I think that many of us have already talked about what is happening all world around, and particularly in low, medium income countries and low income countries, I think that the things are difficult and even more difficult because of political instability. I have felt that as a Ministry of Health, as a Minister of Health, I mean, to know that you have some goals and you have worked very hard to achieve those goals, developing new politics and helping to see which is the goals, right? And then a new government comes and takes everything down and you have to begin again. It's kind of frustrating. So that's a big challenge, I think, for us. Corruption, as always, because there has been always corruption, is very difficult to fight against. The problem with bureaucracy and with decentralization is also a big problem. They are not new, but I think that these problems are becoming more and more frequent in every world, in the world. I mean, not just in low, medium income countries, but also in high income countries. The problem is that we, as low, medium income countries, depend a lot of the help of high income countries. And currently, a lot of programs that we depend on this help, we're gonna lack the funds to keep going with these efforts. So we have to find a way how to do it by yourselves, try to find a way how, for example, Latin American countries can find a way how to support each other, perhaps with coalitions with private sector. Universities are very important also, because if we just wait until politicians help us, we're not going to make it. It's going to be very difficult, because every time that they are changing governments, this going back is every time very frequent. We have to keep educating young people, trying to make them understand that public health is not charity, that is a very important pillar in a society, because even for rich people and for people who is doing investments in a country, they want to have healthy workers, a healthy population. Even for health insurance, it's very important to have healthy people. Otherwise, they're going to spend more and more in treatments than in trying to prevent non-chronic diseases, for example. So we have to show them that this is an investment. It's not like they are wasting money in public health. It's very important also, after the pandemics, we realized that it was very difficult to have medicines and medical devices in our countries, low, medium income countries, for example, because we were depending on other countries to make to deliver for us all these medicine and everything. And it was very difficult for us because we were in a pandemic, we were in the war with the war in Ukraine, and China was so busy with their pandemics there, so we didn't have enough medicines, no medical devices either. So we have to promote the development of these things in our own countries, here in America, in the region. Otherwise, we're going to suffer the same thing. We have to keep improving the education in the community. Community are essential for whatever we are trying to do. Part of the community, and is very important, is media and social media. So the people there has to know what is public health, how to, through the basics, how to improve the quality of life of people, how is important to invest in public health. So I think that we have a lot to do, and I am very glad that we have these kind of events so we can work together.
Thank you. Thanks so much, Jimena. It's creating a durable political support for policies between administrations is a huge challenge for any country. Sumesh, please.
Yeah. So I'll be talking from some country perspective, leveraging the experience of multiple countries and taking a solution lens to this. So we already have this shock that we are all trying to grapple with. But the world has been facing a lot of shocks over last decade, whether it's the multiple disasters, climate disasters that are happening, the increased outbreaks that we are seeing started with COVID, or not started with COVID, they were before pandemic or epidemics before. And then COVID happened, and outbreaks are happening. We have Ebola, we have Marburg, we have Mpox. So it's just the intensity is increasing, right? And then you are having the NCDs also coming in. So I think, what are the strategies that we have that can have most impact for the minimal resources that are available to the countries? So I'll shine the light on a few of these. So one, I think there has been a tailwind, some green shoots and some good thing to be aware about. Post-COVID, I've seen in many countries, public health becoming suddenly a political, not a priority yet, but politically palatable. And countries and political leaders are realizing the power of public health, preventive health, primary health care, etc., in getting them to power next time. And this is happening in multiple archetypes of health systems, whether it's Indonesia that implemented its primary health care program in 24, or India, the primary health care program, or in Nigeria, which has the National Primary Health Care Agency. So, and governments are using it for political mileage. I think there is a green shoot there that we have to leverage and create more traction behind that, so that we educate our policymakers more, so that they can keep investing in it. Secondly, I think the investment in public health has been very fragmented by virtue of the color of the money, as you are talking about. So, given the minimal resources and the multitude of shocks that are happening, I think the governments should be investing, and we should be facilitating investments into a stronger fabric of primary healthcare system, where you provide through a very concerted investment through primary healthcare teams, a minimal set of commodities, diagnostics and drugs, etc., a package of services which is close to the communities. And this is something already getting traction in a lot of countries, but the good news with this is that when there is shock, there is resilience very close to the communities that can, you have frontline workers living very close to the communities, so that you can deliver a lot of services through them. And so if there is a shock to funding for one vertical of funding or other disease program, the entire communities are not starving for the larger needs, the needs of the communities. Also, it is important that since the healthcare needs are changing, and some money is only coming, like let's say, in a maternal newborn health or HIV, a woman or a man or a girl these days, doesn't just have HIV or maternal health issues. She has mental health issues. She has gender-based violence and all of it. And she has hypertension at 50, 55 years or diabetes at 45 years. All of this is coming. So I think a fabric of primary health care is very important for investments, not only for taking care of the women and their families, but also for the global health security, because primary health care systems is where you find the first sign of an outbreak, if you have a strong one. And primary health care systems are the best way to respond to those shocks that happen, whether it's vaccination or increasing awareness among communities. So that's the second one. Third one, you talked upon it, increasing the resilience of commodities and essential supplies by facilitating manufacturing in the global south. That's another very important one that we realized, all of us together, that it cannot be, that there are vaccines, but people are getting 3 vaccines in some countries, and people like the highly needed, people with the maximum need are not getting any vaccines as they are dying. So there has to be more commodity security in the countries. And the private sector, which is there to make money, has to be galvanized to make those investments, facilitated by the private sector enterprises or venture capitalists or what have you. And the fourth one, finally, is as the funding is drying, we have typically been, sitting on our backsides and waiting for the grand big funding to come on our side, right? And we get those 10 million, 20 million, $50 million, and with that we are used to, which has made us very less agile and not looking for efficiencies. Now there are a lot of opportunities for getting different sources of capital, which may not be something that we do it, but also like the multiple stack of capital, whether it's concessional debt for the government or innovative financing, that even if our resources are limited, we can do much, much more with the limited resources that we have, so that the communities and the public health systems do not suffer as the funding goes down for people like us. So these are some of the strategies that I thought I'll share my thoughts on.
Thank you very much, Somesh. And to your point on essential needs, at our conference here yesterday at one of the workshop sessions, the Lancet Global Health released a very important commission on access to medical oxygen. So please check it out on Lancet Global Health. Zoe Mullen, the editor, is here, but it goes to your point about essentials are missing, and it's a critical gap. Thank you so much. Catherine, please.
Thank you so much, and thank you all for being here. And it's so important that we have this cohesive, really global focus so we can be stronger together. I think that's something that I really appreciate, especially given everything going on, so thank you. So I really think a lot about the triple planetary crisis, the biodiversity loss crisis, the climate change crisis, and then the chemical and other plastic pollution crisis. But of course, when we think at the local level, these are all related, they all require attention, and they all have local impacts. So I think the way we need to approach this at a global level and a local level, we have to keep in mind that connectivity. I think that point about the fragmentation that we often see in funding, also in mandates, in workforce, who is equipped, who is trained up, who is really empowered to do what's needed. I think we have a lot of assets that we're not always using in the most effective way. And I think from a One Health lens and some of the work that I've been doing with WHO, FAO, UNEP, and WOA in their collaborative efforts, I think some of these fragmentation gaps are really apparent. And I don't think they're always called out to the extent that they need to be. And so that's maybe an option for really building back in a very strong way that is very durable and uses those assets. And I want to talk a little about the veterinary, the animal health side, and the environmental health side. And I'm so happy that we have veterinarians in the room. I think maybe more this conference than even in prior ones. So thank you for being here. We also have a lot of passionate environmental champions. So whether you're a birder, I know there are some here, whether you're working full-time in environment, that's really a core, I would say, a core global health asset and something that we need more of. So thank you. So really, a lot of the work that I've been doing in my previous role has been really seeing these gaps at the local level when it comes to veterinary profession, whether that's at the national level and strong veterinary systems, or whether that's at the local level with community animal health workers. That's really a core opportunity, really building that capacity, building the bridges with community health workers, more in the human health side, really thinking about the extension services. What the past few weeks, but I would say even the past few years with the declining health investments has shown that, there's not always trust in the things that we might take for granted as global health professionals. I think if it's not always super visible in your community, in your day-to-day lives, you sometimes lose that appreciation. So coming originally from a community health perspective, working in a local public health department, I really see the importance of that. And that's a lesson for myself about how do I more directly contribute in my community. I think we can all play a role in that, and thank you for this community that is helping us to play a role together and share experiences very richly. I would just add to that also with the planetary health eyes and ears, the essential workers on the ground, rangers, eco guards, the role that they can play, being on the front line, seeing things changing in the environment, really being often living in those communities and very exposed occupationally, but also seeing how the environment is changing in ways that really directly impact our health, and the role that they play in that workforce. So investing in that workforce so they have the capacity to also be connected to the public health systems, really playing a key role on the ground all the way up to the global level. I also want to touch on the community environmental opportunities. So I think we often, really want to see more and more investment in climate solutions, in restoration and protected area establishment and management. That's something I really am quite passionate about. I would say the key thing that we often forget is how long that really takes to do that right from a human rights standpoint, and the importance of land tenure, for example, and how that might, if you have 5 years of funding, 3 or 4 years might really be making sure that the ownership is well established and that the community really decides what they want to do with their land. And I think there's a huge planetary health opportunity there when people really see the value of that landscape and what it means for their families, but also future generations. And I don't think we do justice to that, quite yet in terms of what that process looks like and the access to information on the front line. So I think that's really a key role that global health and those working in this field, let's embrace that. Let's make those benefits very visible. And I just want to highlight some very hopeful examples that I have seen. I recently joined the Nature Conservancy, and that's been very enriching to see sort of how things are done in a different way, from a different entry point. And if we think about something like debt and how it can really be intergenerational, multi-generational, maybe there are debts, the interest rates might be low interest, but it's still growing over time, if we think about the cumulative debt. And these debt for nature swaps that have been actually around for about 20, 30 years, but are just really scaling up. And I want to thank Ecuador for the amazing leadership in a very significant debt for nature swap recently that essentially is erasing about $1 billion in debt and really investing in and incentivizing the excellent conservation work that Ecuador is committing to. So I think that's an amazing example. I hope that you'll share more insights from the public health perspective, but it really gives me a lot of hope about what can be done through a planetary health lens. Thank you.
Wonderful. Catherine, so much of what you brought in there, which are key points in terms of, thank you for talking about the triple environmental crisis and the interplay between all three of those, the importance of community development, and also for bringing up that the debt reduction will provide the fiscal space for countries to be able to use resources to be able to invest in public programs. We speak very little about the really tight, enormous debt loads and tight fiscal spaces that countries are enduring right now, particularly LMICs. And for shouting out, so Dr. Ted Mishima from the Association of Veterinary Medical Colleges. Ted, speak to Ted, an amazing leader, and we're immensely grateful for the AAVMC, as Catherine mentioned, bringing veterinarians here. And Dr. Cedric Colmar, if he's here, from VetAgroSup. VetAgroSup in Lyon, France is the oldest veterinary school in the world and doing jaw-dropping work in veterinary sciences and human health. Thank you, Cedric. Elsie, please.
Thank you all for being here. It's quite gratifying to see this room full after 5 o'clock. So yesterday we had a workshop on how to get a job in global health. And I was really impressed by the number of young people that were there. So I think one of the assets we have is the young people that are really interested in global health. And we should take advantage of this. These people should have a voice, and they have, they are really looking at the future and what is there for them and what is going to happen in the future. Many of us maybe we don't have a lot of time left in global health work, but these people are looking at what is going to happen to them in the future. So I think we should really take advantage of the young people. They're interested in doing research. They are interested in what is happening globally. So I think we have an asset in that. But also at that workshop, we were asked how we felt about the prevailing circumstances. And we were given a second to reflect. So I would like to ask you to ask, how do you feel about what is happening right now? Just take a second. Okay, I won't ask you to share with us, but you all know how you feel about it. And I'll give a quote from Professor Omaswa Francis. He's a global health leader, and Keith, you know him well, and many of you know him. He's been coming to CUGH. And he said, unless, and this was particularly for Africans, so he said, unless we in Africa, individually and collectively, feel the pain and the shame of poor health services, we will not have the commitment to take the needed actions to correct the situation. And with what is happening, I think many of us in the low and middle income countries are feeling the pain. Many of us in this room may be feeling the pain, but probably not the shame. But for us in the lower income countries, we are feeling the shame as well. And I'll give you the example of Uganda, where I come from. We have a population of 45 million people. And we have 1.4 million people living with HIV/AIDS. And we've had HIV/AIDS with us. I think Professor Sewankamba is here. He's one of the people that first described it as slim disease in our country for over 40 years. And these people are being looked after by PEPFAR through US funding. And our government has not put money towards that for over 40 years. And we are feeling the shame. And I hope that our governments can feel the pain and the shame, do something about it. We have 3,000 health workers that look after the 1.4 million people. And they are paid with the US funding. And our government, when this came up, because it was sudden, they said they should continue to work and volunteer. And that was painful to me as a health worker. How do you expect health workers to volunteer their services? And so I think during this period, one of the things that we could do is remember, of course, that we are in a global village, but at the same time, engage. For us from the low-income countries, we really need to engage with our governments. I think many times we leave the politicians to decide what is happening. And I'm telling you, this is not easy, especially in some of our countries where there's democracy, but in quotes. So we need to engage with them to feel the pain and to feel the shame and the risk of dependency and see what can be done about it. And I think there could be a silver lining. I know all about the benefits of aid, and please don't get me wrong that I don't understand that. But I think this is a wake-up call for us. And this is not only happening with US aid. I just saw something today about the Netherlands also pulling back and reducing, specifically for Uganda, reducing on the aid that is coming to Uganda. So we need to feel this pain and to feel the shame and see that we put our money where our mouth is. Some money towards the programs. And for those from the high-income countries, to see how we can have co-sponsorship for programs. And I must say that I used to sit on the HRH committee, the Human Resources for Health Committee at the Ministry of Health. And for many years, USAID actually asked the Ministry of Health to have a program to absorb the 3,000 health workers. But every year, this was never put in the budget. And so these 3,000 health workers, highly trained to take care of these patients with a lot of capacity building that has gone into all the programs, they cannot do anything for their patients now, and it's really painful. And they cannot also look after themselves and their families. So we need to design programs that have a sustainability component to them. And it brings me to think about AfriHealth. Right from the time when we had the Medical Education Partnership Initiative, we had 5 aims. I won't go through them. Just the last one was sustainability. And because that was emphasized from the word go, AfriHealth was formed after that to try to sustain the gains of the Medical Education Partnership Initiative. So I think whatever program is being designed, it should have a sustainability component. And as we engage our governments with this co-sponsorship, they should always, I think this is highlighting the consequences of them just sitting back because aid is coming to us and not doing anything about it. Imagine some of our countries, 80% of the health budget is funded through aid from various sources. And then our governments, we are comfortable with that. I think we need to feel the pain, we need to feel the shame, and translate whatever is happening into this, through this into action, and look at, hold our governments accountable. I mean, there's a lot of excesses, there's corruption, which is happening every day, and we have funds that we put into things like the military, and sometimes there's a term they use, I've forgotten what, some fund that you don't really know, it's passed through Parliament, but you don't really know what it's going to do. It's only the President's office that knows how that money is going to be used. I think it goes to security and such things. And we always have budgets that are passed in between, supplementary budgets. But right now, when there's a crisis, there's no supplementary budget for health. So some of these things are really painful, and we need to talk about them. And sometimes our voices in the low and middle income countries are limited because of the circumstances that we are working under. But I mean, the people that are giving us aid, if they can help us to also push and make sure that these programs are co-sponsored, and that if they are running for a certain period, there's a sustainability bit that our governments can continue with these programs. I think that will be very helpful. Thank you.
Thank you very much, Elsie. One of the many great points that you brought up is the issue of having public service integrity as a bulwark against corruption and being able to deliver public programs. And Dr. Omaswa writes in his handbook for health ministers, which is online, and take a look at it if you can. He spoke about that we spend very little time in investing in the public service. And I'd like to ask Jimena, as a former minister, you mentioned how tough it was to get things done. How can academia work more effectively with governments to strengthen their public service, not only in ministries of health, but importantly in ministries of finance and justice, so you can have a system and a structure of checks and balances to reduce corruption?
Yes, thank you for the question, Keith. I really think that it's difficult to change the way of thinking of politicians. And the problem is that every time that a government is changed, here in the US is every 4 or 8 years, but in our countries, in my country, is perhaps every 1.5 years or 2 years. So the things are incredibly difficult, because, I mean, I was 13 months in charge of the Ministry of Health, but during this time, I think that they have changed like 5 times in 1 year, the Ministry of Health. So if we keep relying in changing the way of minds of politicians, I really think that we are wasting our precious time that, as you just said, is very short, is very little. So I think that we have to keep educating the population, the community, the people. As academics, we have to keep educating young people to change their ways of mind, because when they arrive to power, they are going to do the things different. I think that they are the only hope. And we have to keep trying to promote this kind of events, to work with academia and with private sector, with municipalities, that I think that they are more stable politically than the central government. Local governments are more stable and very important. They have to provide water, they have to provide sanitation to the populations, not just, I don't know, perhaps something so superficial just because it's visible for the people, but the really things that are important. So that's the only way. We have to change from the basis. I am speaking from the from my experience, to change the things from the top of the pyramid is almost impossible.
Well, that goes to Catherine's work in the community level, because the rubber hits the road at a local level. And Catherine, perhaps you could share from your extensive experience in West Africa how maybe institutions can work with communities to strengthen their capacity to deliver the public programs that they want. And you can consider, please do weave in the incredible opportunity, as you've spoken about it at length and written about it at length and worked on, the importance of actually protecting ecosystem services as a way to not only address the triple environmental threat, but also deliver public programs and generate resources and jobs at a community level.
Thank you so much. Well, I think that there's a lot of opportunities, which is the good thing. In West Africa, the village chief it holds a lot of importance. Village elders hold a lot of importance. If we think about context-specific actions and engagement and the right way of doing things, I know, with the Ebola crisis in West Africa, there was a lot of concern about people coming in with coveralls, for example, and that sensitivity about, okay, how do we engage in a people are scared for a good reason, and there were a lot of outsiders coming in, and I'll just give the example from my previous work where our colleagues from the Society for Conservation of Nature of Liberia, really went in and built the trust, and that took a long time, and as it does, and you need to account for that when designing projects and investing in that, and if you're working in a lot of communities, that is a lot of investment of time, but that is so critical, and something that after a lot of engagement with those communities, of feedback was that, wow, you actually came back and you have given us really useful resource and the chance to ask questions and have dialogue, and some of that is so important. And some of the questions I've gotten, I did some work on Rift Valley fever in South Africa, and a lot of the farmers had really essential questions that showed that they just were not getting always the key information that they needed. How old is my cow? And how do I tell? And some of these things that maybe we really take for granted, and we don't always have all the answers to, but these are great questions, and people should have this information, and they shouldn't be, not having access to this when it's their livelihood or they really want to do the right thing. So I think that gap of, again, the eyes and the ears of who's on the ground, and I think in Liberia, for example, the rangers are living in those communities. So very integrated, their families are there, they're hearing the concerns. It raises some challenges with, say, enforcement, for example, of wildlife crime, environmental crime. It's not an easy dynamic always, but it also gives the opportunities to really have trust. And so when there's information from the rangers, or they're hearing information, they're such important messengers. And so if they're seeing something like communities not having access to water, wells being broken, we need to have that system that works so that those rangers can go to the municipal resources or public services and say, look, you need to help this community have access to water as a basic health right and human right. And I think right now those systems don't always work, even though they should, even though there are quick fixes, and that's again where that you might have availability of things, but you don't always have access, and that's a key. How do we empower those communities to really be able to advocate for what they need, and make sure that leaders are accountable to them for those important basic health rights.
Thank you very much, Catherine. Jimmy, as an ambassador, you have to make decisions with an imperfect level of knowledge and important decisions, and in academia, work on a higher level of smaller appetite for uncertainty. What does the audience need to know how can academic institutions engage more effectively with embassies and be useful partners in being able to work on the development programs they need to?
Great. I think, as we know from the kind of people who are here, the desire, the interest in that from the scientific, academic, global health practitioner side is greater, unfortunately, than from my profession. I don't know a lot of diplomats who say, I really have to learn epidemiology as a second language so I can figure out what my options are here, or how do I evaluate this data. And so, first of all, I mean, if you're a scientist and you see a pattern or an anomaly, you collect the data. If the data is strong enough, you publish in a peer-reviewed journal, and the article always starts with assumptions and ends with more research needs to be done. If you're an ambassador and you have to make a kind of now or never decision, do we try to scale up antiretroviral treatment to the 150,000 people in Uganda who already need it this year, and suddenly we have this program PEPFAR that's going to provide it? How do you analyze that risk? How do you deal with the unknown, the idea that more research needs to be done? And how do you then put that priority onto other people's agenda? Who are these other people? Often political leaders of other governments. And then what are their agendas? How do you get them to own this idea? And so if you kind of think in that mindset, if you're a medical or academic person, of how are you going to put your priorities onto other people's agendas, you have to say why it's a priority, and the data doesn't usually speak for itself, but then you have to figure out how to get this sustainable. And I have to say, in my job now in trying to get the United States government, at least, and I think we may be ahead of many other governments, to see health collaboration, health issues as important bilateral issues in peacetime. There doesn't have to be an outbreak for us to need to know, just like we do about a dozen or 24 other issues in every country, what's the local capacity? Who can we trust here? If something happened, what would we do? Who would we call? Do we have resources in the US that could immediately be deployed? And if so, how would we go about doing that? Who flips the switch? How do we create political will to respond? And I think that whole sense in which diplomats, if we're good at our jobs, and some of us are, have thought about a lot and have to be in the pattern of thinking about for unexpected events or for fast-moving events. We've rarely applied that to health. Health has been something that was taken care of by technical experts, and that ambassadors and people in sort of foreign policy positions didn't see as their top 10 priorities. And I think we just have to change that, and the community here can help, first by defining why it's a priority and why it should be on our agenda, but also look at what are the capacities that you have, how do you add value to the capacities that people in Ecuador or Uganda have that could actually help us achieve mutual goals. So I'm sorry, it's just a mindset, but it's one which diplomats are not trained for, we're not selected for that, and in most of our experience, we haven't had the opportunity to say, yeah, this should really be part of bilateral relations, part of our definition of what security is for our own countries.
And it is important for the community, our community, to understand your realities so we actually know how to engage in an effective way. Security is beyond just the big H word that we use, and we need to understand that and perhaps frame our benefits in a broader context, perhaps. Elsie, as the former president of AfriHealth, some AfriHealth members here, but most are not. How can non-AfriHealth members engage more productively and effectively with AfriHealth members as defined by your community?
Thank you. Yeah, AfriHealth is an interdisciplinary, interprofessional network of networks, and our membership is both local and global. And so we're open to collaboration, and we really value partnerships. So we have many programs that we are running, and we have many partners, but we still need more. And our areas of focus are really, one of our areas is capacity building. And we are running programs on leadership, and I think this is very, very important. And these courses on leadership are oversubscribed. Because of limited resources, we can only train a few people. Those who were in the session that we've just had, that was organized by AfriHealth, who talked about this. And we need capacity building in the areas of leadership for our health workforce. Of course, there are also many other areas where we need capacity building. So all partners that would like to collaborate with us, we are open, because the needs are great in our region, and we recognize that there's a need for us to work with others to build capacity. And we also hold a symposium just like CUGH annually in a different country within Africa, so that we can meet partners and also, of course, the locals from that region. And this year is going to be in Dakar, Senegal in September. So we would like people who are doing work in West Africa to join with us, and we talk about the issues specifically for West Africa, and we see how we can collaborate and how we can use the lessons learned in those programs in West Africa to disseminate them across the region. So partnership and collaboration is key for AfriHealth, and we are really open to learning from others and also sharing our experiences and our knowledge with the larger community. We actually realize that we are in a global village. Whatever happens in a small part of Africa could easily escalate and go to any other part of the globe. So that's why we would like to work with as many partners as possible to improve the health outcomes of Africans and also others globally.
Thank you very much, Elsie. And you, Dr. Andrew Dykins, and others helped to create the capacity building site, which is CUGHcapacitybuilding.org. If you have a chance, go online. It's free to use. And it's a great, it's like Match.com without the romance. So, but it's a great place to help to build capacity or share your capacity building assets. I'm going to, before I go to Somesh, please, we'll go to questions after my last question to Somesh. There are mics here. I don't know if there's a mic over there. But yes, there is. But please use these two mics if you can, and keep your question to a minute so we can get through as many as possible. So after Somesh, we're going to go to you. So please line up. Thank you. Somesh, you're JPIGO. You're a leading implementer in the world. Can you share with largely the people here are from academia, how can they work more effectively with an implementer like JPIGO? Sometimes there's a divide, right, between the implementers and academia, but both have assets that need to complement each other. What advice can you give to the audience with regard to working effectively with an implementer like JPIGO?
Sure. So few things, right? One is, when we're talking about lower middle income communities, where I also come from, you're talking about health systems for resilient change, for long-lasting change, and that will require in the new age health workforce which is ready for the future. And I think academia has a big role to play there. Traditionally we have created we are living currently in a different paradigm of creating health workers which are highly specialized in many cases, have a very long and expensive way to complete their education, regulated with degrees. And as we go into the new age, we will need a different kind of a health workforce which is taking care of not only the erstwhile maternal, newborn, and HIV needs of population. They will need mental health. They will need to be technologically savvy. They will need to be prepared for when the people have their access of their Google, and they know what they may be suffering from, or at least they have an idea, an opinion about it. So the short of this is, we need a more versatile health workforce, and we have been talking for last 40 years, invest in health workforce. Hire, you're short of 50% short of nurses, or 40% short of specialists, or what have you. It has not changed over the last 40 years. What do we think will make it change in next 10 years? So that's where I think one area that we can come together is think around a different paradigm of health workforce that can add resilience and agility to our health system. Second is on institutional capacity. Governments in our countries, lower middle income countries, they want their institutions to be strengthened so that they do not have to access us always for best-in-class technical advice. And so that strengthening of that institutional capacity as they start investing in their institutions is another very strong way to support governments for their technical assistance needs. And finally, customizing our research methods. I've written a paper on harmonizing political rigor with harmonizing scientific rigor with political urgency. And it's talking about, a middle paradigm where, we customize ways of doing research and generating knowledge that can also meet the political needs of people in power today or people in need today in real time, not with some evidence that takes 10 years through an RCT to come. So customizing our research methods and having a much more closed wedge with the implementation pathway and policy paradigm of the country. So these are a few thoughts on that.
Thank you very much, Somesh. Now we'll go to the audience and Q&A. Please keep your questions to a minute and direct them to somebody if you can, please. Yes, please.
Hello, my name is Alan Tulos. I'm representing Deloitte and our international development practice. I was recently working on a health system strengthening project in Ukraine. My question is for Dr. Kumar. You mentioned that large grants have made us less agile, and then you started to mention that we should be looking for sort of other sources of funding and financing. So as a fellow implementer, what would you recommend, or where do you sort of see other financing options coming from? And then I just have one comment to build on Ambassador Kolker, and something maybe for the group that could benefit the group, is that the Secretary of State has said that his mission is to make America strong, secure, and prosperous. And the best sort of quote that I've heard about public health is that diseases don't respect borders. And I think we can really take that quote and really speak to when we're talking to decision makers and policymakers, connecting that diseases don't respect borders to that's how we make America secure. And then also connecting that to prosperous, right? Affecting the public health of a country also affects their economy, right? So we can hit two main goals of Secretary of State Rubio when we speak to those. Thank you.
Great. Thanks, Alan. We'll take the questions here, then we'll go to the audience. So much that's for you, but we'll go in this direction. Yes, sir. Then we'll go to Quinton, and then please go ahead, which I can't see. And then we'll go to the responses. Please.
Hello, my name is Suresh Rangarajan. I spent some years abroad in Vietnam and Thailand. I just want to say I worked for the State Department in Thailand and was instrumental in identifying the first Ebola case coming into Bangkok. Was a huge pickup and worked very closely with the Thai government and the leading medical institution to stop that case from entering the country. So there's a huge role of the State Department in pandemic coordination. And so the Thai government was very thankful, and it was a very solid diplomatic moment for both the U.S. as well as the Thailand government. But I wanted to really talk about this question of shame. I was a care and treatment director of a PEPFAR program, large program, 40 clinics, and I was fortunate. I was in a little bit of a higher income country, not in Africa, I was in Vietnam. And this transition was the whole emphasis, and it was really a struggle. And I just want to say the shame doesn't just rely on your leaders, it also relies on us. We tried really hard to transition, and sometimes it didn't go as fast as we thought. But it's because I think there is this urgency that we don't acknowledge, that we try to create vertical programs because we're trying to scale up so quickly. And we didn't really think about the transition when we started our work in rolling out ARVs. And so I think that the message that I learned, in that we got lucky because there was a social insurance scheme, but if I was to be in the same situation before, I would have proceeded very much along Sumash's line about transitioning to primary care, moving away from like single-funded disease programs to primary care. So I actually am a primary care physician now in the States. So my question to the group here is, what other disease programs across the world in your countries do you think could be implemented into a more expanded primary care system to be more sustainable?
Thank you very much. And then Quinton, and then yes, sir, then we'll go to the answers. If you keep your questions to a minute, appreciate it. Thank you.
Yeah.
Thank you.
So yesterday, as some of you may know, we had a full-day workshop which I co-moderated and spoke about on public-private partnerships. And I was glad that at least one speaker brought that up, because I think that is something we have to think about very carefully. So my question to all the panelists is, how do you view that? There's been certain resistance to it by academia about entering into these partnerships. I'm just curious what perspective you take, whether you're prepared to go that route, particularly in low and middle income countries. Is that a viable option? And if, how do you view it? And are you actually taking active steps in that direction?
Thank you, Quinton. And then last question here before we go.
Hi, I'm Joel Kmeyer. I'm the Chief of Infectious Diseases at Wayne State University in Detroit, and I have two comments and questions. The first is that I've been thinking a lot in this moment about how one of the most important consequences of this moment is going to be the displacement of some pretty highly skilled professionals from the federal workforce. And these are people that have developed expertise over a lifetime, and it's not easily replaced. The backstop for a lot of those people is going to be employment in the university systems. And I think it should be our mandate for those of us that work in academic systems to think about how we can continue to capture this expertise. And so my first question, perhaps to Ambassador Coker, is to how we might do that. The second comment that I will make follows from the first, which is that I really think that CUGH specifically is going to be one of the most important global health NGOs in the world over the next 4 years, as we think about how we fill some of the backstop to what the federal government is no longer providing. And so I guess that this question is directed to Dr. Martin, which is just what structural or strategic changes do you think are necessary within CUGH to kind of expand what we do and what we accomplish, given that the federal workforce may not be filling the same roles that it has in previous years. Thank you.
Thank you very much, Joel. So we'll go to the first question. Samesh went to you from Alan.
Yeah, sure. So thank you for the question. It's already happening in some places. There's a concept called multi-stack funding, a fancy word for just different sources of funding to break the logjam where we want the government to put in their more resources, but the fiscal space is so limited, they are in debt burdens, etc. So how do you break that logjam? And especially now with that, the large amounts of funding that go in through us or directly to the government it will be reduced. So essentially, this includes sources of funding like reaching out to multilateral banks, for example. We have talked to, now many governments are talking to the multilateral banks, whether it is Asian Development Bank or Inter-America Development Bank or African Development Bank for financing their health needs and health system needs. These banks have typically supported the building of roads and power stations, etc. But that's the infrastructure that they know. But now, as the politicians are realizing that there is political capital also in the social infrastructure, they're asking for that need. And so, but it has to be also done more intentionally. Then there are governments who are also releasing their own sovereign bonds. Cities, they are releasing municipal bonds for strengthening their city health infrastructures. So, and so these are sovereign bonds. And then there are other concessional debts that banks in all of these countries, they want to also participate in their social good. So if they issue fixed deposits or those kind of deposits where they give an additional 0.5% or 1% for people investing in some investments which invest in government's health systems or public health systems, it's a win-win for both, and it comes from banks' social corporate social responsibilities, which eventually adds out a lot of money, and it's win-win for the bank as well. And finally, a lot of innovative financing where social investors want not only to invest in profit but also in social cost. So if they say that okay, if this country can reach to a 95 target, and they give me $100 million, if you reach there, I will give you $100 million then. But then I may be a government in this case. But for then I may need to get some capital to get there. So there are these multiple tiers of funding which can then be supplemented by a much smaller grant funding to help it all bring together. So those are some of the ideas. Again, I am not an expert on financing, but these are things that I have seen working out and green shoots happening in many of the emerging economies of the world.
Thank you very much so much. And on the primary care question that was asked, second, who would like to take that? I'll see you.
Thank you. If I got it right, is what diseases should we take on for the primary health care system? And I think for us in if I give the example of Africa, I think the training for health care workers at the moment, we need to train generalists that can take on nearly, of course it's difficult, but at least they can take on nearly everything. Our training, for example, for doctors in most of the African countries would do 6 years, 5 years of training, and then 1 year of internship when you work under supervision. And you get a bachelor's of medicine and surgery. And so that kind of person should be able to handle nearly whatever comes to them. And then we have a few specialized physicians to do the rest, because most of the diseases we have are really preventable. So emphasis on public health for our trainees is important, and also training them in the communities where they are going to work so that they really understand these communities is also key. So I think all our, be it nurses, be it doctors, they really need to train for primary health care, and then we get a few to specialize until we get a health workforce that is big enough to handle what we have. I don't know when that will be, but for the time being, to have to let physicians or health workers specialize early, I think it would not be a good way to go for us. Thank you.
Yeah, I'm going to start with the vertical programs in primary care. And the PEPFAR, the President's Emergency Plan for AIDS Relief, changed a lot of lives, and mine was one of them. And I was ambassador to Uganda when it started. And what was different about PEPFAR, one of the things that was that previously all of the U.S. health programs I'd been familiar with, and I'm by no means an expert, I have no credential to be here at all, but were pilot programs, proof of concept, or center of excellence. People doing one thing at one site that worked. but no one ever scaled it up. And PEPFAR's ambition was to bring treatment to everyone who needed it. And that national scale-up aspect of it really was transformative in terms of what our engagement is. And yes, it's a vertical program, but in order to do that, you had to master a lot of other skills of supply chain and political and economic responsibility and workforce and a whole lot of other things that we've been talking about. And so sometimes words are important, and this is, maybe I spent too much time at the World Health Organization, but the primary care is, as I understand it, what's done in clinics. So a lot of what we're doing isn't primary care, but it is primary health care. So if we're interested in surgery, if we're interested in non-communicable diseases, or we're interested in mental health, that is part of primary health care and universal health coverage. And I think as we look about how to change our whole approach, and maybe the next phase of USAID or whatever comes after it, we'll think not in terms of proof of concept or pilot program or center of excellence, but how do we look at universal health coverage? How do we look at primary health care as something we can contribute to, maybe through a vertical program, but certainly with the consciousness that we're in an ecosystem that needs all of that. And I'll just comment briefly about the stronger, safer, and more prosperous. I mentioned those in my talk also. We do have to look at all of what we're doing and saying, yes, let's make these connections. Let's connect these dots very consciously of why that is. And it's obviously true for outbreaks. But the idea that Rwanda was able to control Marburg and Uganda is now controlling Ebola isn't an accident. These were programs in which the U.S. has invested over decades and trained people, built systems, established professional relationships. Many people were involved in institutions that are represented here. And so I think we also need to be sure that we're consciously talking about why programs, even that don't have an immediate life-saving effect, actually do contribute to stronger, safer, more prosperous world and nation. And it's not obvious. Not everything we do is a direct connection, and maybe we'll have to do some triage or figure that out. But we do have to make that connection very specific and visible as we're talking about what we do in our narratives, but also in our practice. And then just one last talk about the capacity. I mean, that's absolutely right, and we're a month into this, and we don't know where this is all going to end up. But I think the sense, again, that we are a community and that we're taking care of each other, we recognize that expertise on both sides, the academic side and the public servant side, is really important. How do we capture that? I think I've been impressed as a practitioner that more and more schools are having professors of practice or adjuncts who will talk about their experience in actually implementing programs. There were long sessions on implementation science here. And I think the idea of how does that fit into the other things you're doing, how does that meet students' needs, what do you give up if you're going to have people talk about their adventure stories from working in the field. But it's really important, and the idea both of valuing the experience that people have had and their expertise, and seeing that, yes, this is something that needs to inspire the next generation, and to be sure that we're honoring in the way we talk about our profession is really important. I wish I had a more specific answer.
Thank you very much, Jimmy. Any other points to Quinton's question? Others, I'll respond. So, well, that was an easy question about what's going to happen to all the displaced workers. It's not only affecting here, obviously, but we get calls in the office all the time of really heart-wrenching stories, and Elsie knows this best of all here, and obviously can speak to it. But this is a wrecking ball through the lives of people around the world, right? And not only them, but also the people that are dependent upon their care broadly. So from our perspective at CUGH, we had a strategic plan with the board, as Jimena and Elsie know, and we're working together in this new environment to create very quickly create a strategic plan that will enable CUGH to operate effectively to meet the needs of our members and people around the world, to improve the health of people and the planet. But if I can say that, what would that look like in part? First, of course, is advocacy and communications. We have here and around the world, obviously all of you are powerful citizens within your country. If we're going to be able to change at least in this country, the political calculus of why people are not responding and are willing to subject themselves to allow what's going on to continue, they're scared. They're scared for their jobs. So what we have to do is make the fear of losing their job greater than the fear of what we call being primaried by the current president. And we can do that by being able to work with the public. And what's really important for all of us is to engage the public, to inform the public in language that they understand about how what is happening is affecting them in their lives, and that they take that message to their elected officials and say, if you don't stop this, we are going to get you out of a job. If enough of that pressure happens, then what happens, I can tell you this as a former member of parliament, is that you have somebody in your office, in your constituency, and Jimena knows this as a former minister, and you know this as ambassador, writing down the calls you get, the notes you get, the letters you receive. And once that starts to pile up, believe you me, that politician takes notice of what that is. Once we can mobilize our members on a sustained level to put that pressure on them, then the fear of losing their job by their own constituents supersedes the fear coming from their leader. And that's the sort of the calculus that what we have to consider and what we need to do. Second is how we can actually also assert a better way of doing global health. You know, it's not right to say everything was fine. We know that. But we can muster at CUGH, working with you, to find a better way, a more effective way to use the resources we have to create sustainable, durable outcomes on the ground with partners on the ground, so that countries will be able to manage their own affairs and be able to deliver better programs to the people. So one last thing, which you don't talk about enough. You know, a colleague of mine said, you know, in politics we have a saying, no money, no runny. Well, no money, you can't do what you want. ODA, official development assistance, is about $140 billion a year. Money lost to corruption is about $1.5 trillion a year, or as Christian Lagarde, the former head of IMF, said, possibly up to $3 trillion. A good chunk of that is taken from where? Poor countries. Where does it wind up? Our countries. We are part of the problem. That money is laundered through our systems, put in our countries, in our assets, at the expense of poor countries around the world. That has to stop. And we can do something about it. And that's something that thanks. Because that would liberate and get the money back to the countries and the people that need it, as both Jimena and Elsie said. Jimena, do you want to talk about corruption? Because we've spoken about that. Do you want to just say a little bit about what you faced, if I can, as a politician, as a member, as a minister, how tough that is?
Well, I was thinking that perhaps I could wear a positive hat later after what I just said, but I'm going to make just a little comment. I was trying to change the health system in Ecuador. We developed a whole program to improve the health system, to improve the collaboration between the subsystems, and to improve the amount of medicines and devices that we had in all the hospitals, trying to involve international aid, like PAHO, for example, or World Health Organization, and everything, I mean. I mean, the politicians didn't like it. They just didn't like it. And they made riots against the government. They get rid of the government. The President Lasso, who was the president when I was the Minister of Health, had to close the Congress because of the deep movement that was there because they were trying to get rid of the president because he was trying to make the things right. And he just, I mean, he couldn't do anything. I have to left office also. I was awarded with a condecoration. I think that I was the first Ecuadorian woman to be awarded with the National Award for Merit. But anyway, I had to leave office because the political pressure was so tough. So that's why I think that it's very difficult to change the things from the top to the bottom. I think that we have to change it from the bottom to the top. But I don't want to lose the opportunity to say something that is positive. We were able to tackle the pandemics before many other countries in the world. We vaccinated 9 million people in less than 100 days. And I mean, we didn't feel the heat of Delta or Omicron in Ecuador. We stopped the pandemics, and it was not just the effort of the Ministry of Health, but also the goodwill and the support of the leader of the country, who was the president by that time. And we were working, all the Ecuadorians were working together. The private sector, the people, the ministries, of course, because we're part of the government. The Ministry of Finances, they give us the money that we needed for buying vaccines and to hire more people. The army forces, I mean, everybody was working together to achieve the same goal. And I think that we can repeat the same in the whole world. I mean, if we work together to change, to improve global health, to improve public health, we're going to make it. But we have to have the same goal. I mean, we have to fight for the same things.
Thank you, Jimena. And we're going to do a last, We need a positive message. This is great. So on a positive note, each one of our panelists are going to give us a positive note to take away of what we can do. And we're going to go in reverse. Elsie, please.
So I don't want you to go away feeling the pain and the shame. So I'll just say that if we want to go fast, go alone. If you want to go far, let us go together.
I just want to pick up on the point about new partnerships, public-private partnerships. I think also NGO and university and industry partnership. And something really exciting I've been learning about recently is, the Nature Conservancy is a landowner in the US, but also elsewhere, and works with a lot of local partners, including farmers. So if we think about, phasing out harmful subsidies and really phasing in these healthy subsidies, even organic certification and the time window that, the losses that farmers would incur during those 3 years to certification, providing subsidies so that they can really weather that loss for those years before getting the premium pricing for organic certification. I think we could look at that for many different contexts from a global health lens and really encourage those really positive, health-positive subsidies. And I just want to say also, to really celebrate some good news, the Global Fund recently launched a climate and health investment. It's way too small, but it really acknowledged that TB, HIV, malaria, these are only really getting exacerbated by the climate crisis, and all of these climate-related disasters only make us more vulnerable. So I think that focus on resilience and integrated programming, it can really be very powerful. I hope we see a lot more of that. Again, I think there's a role for private sector encouraging that, but I think that's some positive light that we see.
Yeah, so the positive note I'll end on is public health and primary health care, the most important things that we have been talking about, is gradually becoming a political priority, and people are asking for it. And when we know when people ask for it and when things become a political priority, they happen. So that positive change has started to happen. Are we there? Absolutely not. But it is the last 5 years have seen a movement which has not happened in last 30 years. So that's a great trajectory that if we should all leverage and try to give more tailwind to.
Well, I just want to say that it's important for us to go outside of our circle, because everybody here thinks about the same. We share the same principles and we share the same goals, but we really have to reach other people who are not involved in global health, and they don't know what is global health or public health. So I think that each one of us should approach any person and tell that person what is global health, what is environmental health, what is One Health. And so we can share our knowledge in a simple way and be able to make the change.
I wish I had thought of everything that everyone else had said, but one thing that I've experienced even in the last 24 hours here is what a resilient community this is. And we don't disagree with each other. We know why what we do is important, but I think we have to think about how we're presenting this to external audiences. What is it about our narrative? What is it about about putting our priorities onto other people's agendas that's especially valuable today? And I think this conference has given us a great opportunity to practice that, but also let's continue to learn from each other and find out what are the messages and how do we present them the most effectively, because we know why what we do is important. We know why it's important to the United States and to the partners that the United States has, and we just have to be sure that that message is more clear than ever.
It's so true, isn't it? We are here united, and we have to spread this message to others who have the kind of concerns and problems and challenges and fears that all of us have, regardless of political stripe. And I think, folks, what a wonderful panel we've had today on behalf of all of us at CUGH, Elsie, Catherine, Somesh, Jimena, and Jimmy. Thank you very much for lending your expertise to this family that we have here. And thank you very much for giving us such a positive message of going forth and being able to be effective in these challenging times. Thank you.